Good afternoon, everyone, and welcome to our April Joseph Priestley Society meeting. My name is Bill Tyzinski. I'm the program chair for JPS, and we're pleased to welcome Amit Parikh of Smith and Nephew. Amit is a research manager for the company. Smith and Nephew is a manufacturer of hip and knee implants, and he'll be talking to us about the past, present, and future of that technology, of hip implant technology. This is, I had seen Amit speak or heard Amit speak at the Virtual Society of Tribologists and Lubrication Engineers Conference last year, and immediately recognized this as a perfect JPS talk. Covers both historical developments and also a lot of innovation and entrepreneurship on the part of Smith and Nephew. So we're excited to have it. For me, it's timely because my wife just had knee implant replacement technology surgery last week. So, but I couldn't get him to switch over to doing knees. We do hips instead. So with that, I will mute and disappear, and I will turn the floor over to Amit. One last item, if you do have questions, put them in the chat box, and please ask early and often, and we'll get to as many of them as we can at the end. Thank you.
So thank you for that kind introduction, Bill, and thanks for the invitation to speak today. As mentioned, my presentation will touch on the past, present, and potential future developments in total hip replacement. It's quite a broad topic, so my slides will skew a little bit more towards the material side. While some of you may be familiar with hip replacement, which is also referred to as hip arthroplasty, I wanted to start with a general overview just for those that aren't as familiar. So simply put, hip replacement is a surgical intervention involving replacement or resurfacing of the hip joint. And the intention is to relieve pain and restore joint function. It's most commonly used to treat osteoarthritis, but it can also be used to treat other ailments such as femoral neck fracture or rheumatoid arthritis. On the left of this slide, you can see a skeletal schematic of a healthy hip joint. Within the joint capsule, you have healthy cartilage covering both the acetabulum and the femoral head, which is at the proximal end of the femur. The second schematic is intended to reflect an arthritic joint. You can see degradation of the cartilage, which can lead to a narrow joint space, painful bone-on-bone contact, and inflammation. Finally, the third schematic displays a typical hip replacement device. It consists of a modular femoral head that's locked on to a femoral stem, and the femoral head is free to articulate against a polyethylene liner that is in turn locked into an acetabular shell. And this last schematic, of course, shows it in the skeletal schematic. So I want to speak a little bit about the origins and development of hip replacement to give you a bit of an idea on how we arrived where we are today. I thought this quote was appropriate because as I highlight the contributions of a select few in the upcoming slides, it should be recognized that there are certainly many contributors to the advancement of hip replacement that are unmentioned, but that's not because they don't deserve credit. The first known hip replacements were what we would call partial hip replacements today, in that they only resurfaced one side of the joint, namely the femoral head. Dr. Themistocles Gluck, who practiced in Germany, is often recognized to perform the first joint replacement using femoral implants that were made of ivory. And while his first patients did well in the short term, many had to be revised or failed for infection. Over the next few decades, various devices were implanted and investigated, including others made from ivory, some made from rubber and glass. While metals were attractive, there was an experience by the early 1920s that in the fracture fixation space that highlighted that the body was quite a corrosive environment. So at that time, there was not a metal that had been identified that had adequate corrosion resistance, was well tolerated by the body, and exhibited mechanical properties required for joint replacement. That changed in the late 1920s when the metal cobalt chrome began to be used in dentistry. Cobalt chrome alloys were originally developed and patented by Elwood Haynes, who called them stellites. He used them to make cutting tools, which his company widely sold. Interestingly, Mr. Haynes had a varied interests and was also known for coming up with an idea of a horseless carriage in the late 1800s, and he built one of the earliest road-tested gas-powered automobiles. Nonetheless, an argument can be made that his contribution to joint replacement was equally consequential. So after being introduced in dentistry, a cobalt chrome alloy called Vitalium began to be used in joint replacement in the late 1930s. There were a wide range of early designs. As you can see in the first images on the left, some were just caps that were placed on the femoral head. Later designs included a stem to assist with fixation. During this time, other materials were still being investigated as well. For example, in the second set of images, you can see an acrylic device that was tried briefly before being abandoned in favor of cobalt chrome. By the early 1950s, Austin Moore and Frederick Thompson both separately developed Vitalium partial hip replacement components that incorporated a stem that was pressed into the medullary canal. And this is a design feature that continues to be used in modern designs. So while there have been previous attempts to resurface the acetabular component, the first device that performed relatively well after replacing both the femoral head and the acetabular surface was developed by McKee in 1951. It was a cobalt chrome on cobalt chrome device that incorporated spikes on the outside of the cup to promote mechanical fixation. Over the years, McKee and his collaborator Watson Farrar experimented with a number of different stabilization techniques. While the outcomes varied a bit, they were promising enough that the idea of total hip replacement appeared viable. So this brings us to Sir John Charnley. Charnley conducted friction measurements in the 50s and found that healthy joints have extremely low friction. And this is because of the unique properties of cartilage and synovial fluid. He concluded that low friction was an important attribute for a replacement device. And this led him to PTFE, which is also sold under the brand name Teflon for other applications. His initial hip design incorporated PTFE on both the femoral head and the acetabular side. As pictured, they didn't perform that well. He went through several other design iterations in the subsequent years, often making the implants himself at his home workshop or at the hospital workshop. He ultimately decided to pair PTFE with a stemmed metal femoral component and chose a 22mm diameter in order to minimize friction. His early results were quite positive. However, most had to be revised or replaced within 3 years due to severe wear and an inflammatory response to that wear debris. So in trying to improve outcomes, Charnley and his technician, a man by the name of Harry Craven, evaluated several different variations of filled and impregnated PTFE. Unfortunately, the results were no better, but fortuitously, they tested ultra-high molecular weight polyethylene, or UHMWPE, after a salesman that was selling gears and plastics visited his hospital and left them with a sample of the material. So for those that may not be familiar, polyethylene is a semi-crystalline material consisting of long carbon chains with hydrogen bonded to each carbon atom. A UHMWPE, or ultra-high molecular weight polyethylene, is distinct for the length of the chains, and its molecular weight is in the 3 to 6 million grams per mole range. And it's this high molecular weight that gives it improved mechanical properties over your everyday polyethylenes. So this material performed quite well when Charnley tested it. In fact, at the bottom of the screen is how he recorded its performance, commenting that after running night and day for 3 weeks, it performed better than PTFE had in 24 hours. Still, due to his experience with PTFE, Charnley was a little bit worried about the inflammatory response to polyethylene. This led him to conduct an experiment that is a bit remarkable. He actually implanted pieces of both PTFE and polyethylene in his own thighs. These were implanted subcutaneously, so beneath the skin. And despite recording some early symptoms at the implantation site for PTFE, he persisted with the experiment up until 9 months. And at that time, he recorded that he could distinctly feel nodules around the site of PTFE implantation, and that those nodules were about twice the size of the material he had implanted. In contrast, the UHMWPE site was much less distinct. So after this experiment, Charnley began implanting UHMWPE acetabular components paired with cobalt chrome femoral heads. And based on his successful outcomes, others followed suit. While designs varied, polyethylene paired with cobalt chrome heads were widely implanted for subsequent decades, and Charnley's pioneering work in this area is widely recognized. He was actually knighted in 1977 in recognition. So while the introduction of polyethylene greatly increased the life of hip replacement devices, the failures that did occur were often due to loosening. This loosening was caused by cellular response to debris in the joint space. While the initial response is inflammatory in nature, involving macrophages, a subsequent cascade of reactions ultimately impact the natural bone remodeling process, resulting in bone resorption or osteolysis. So in this radiograph shown, you can see the implant surrounded by bone cement, which contains a radiopacifier, making it visible. Outside of the bone cement, you see these radiolucencies, which are indicative of bone resorption. So as this resorption progresses, the implant will eventually become loose, necessitating a revision. Another observation that occurred as the devices were revised was that some cobalt chrome heads exhibited scratching, and this was likely caused by bone chips or bone cement debris. The presence of these scratches prompted concerns that where it could be accelerated. So while the utilization of polyethylene with cobalt chrome heads was a large step forward in hip replacement and greatly improved longevity, there remained room for improvement, and wear-related concerns remained at the forefront. In subsequent years, a number of different polyethylene materials were developed and introduced. For example, Poly 2, which was a carbon fiber reinforced polyethylene, was commercialized in the knee. Another example is Hylamer, which was a highly crystalline UHMWPE. Unfortunately, neither performed as well as desired, and both were ultimately withdrawn from the market. In approximately 1970, ceramic on ceramic bearings were utilized for the first time. Ceramics are attractive because they have the potential to have very low wear. They have really high hardness, are very abrasion resistant, have low wettability, improved wettability over metal, so they are wettable. However, some early ceramic on ceramic devices exhibited incidences of fracture and loosening. Over the years, ceramics have improved significantly. So they have fewer impurities, smaller grain size, and as a result, they have much better bending strength and fracture resistance when compared to ceramics of the past. So this slide displays modern ceramics used in hip replacement. They largely come from a single manufacturer, Ceramtech, who produces implants for various companies. The image on the left displays a device that incorporates alumina, while the image on the right displays zirconia toughened alumina for both the head and the liner. So these designs are incorporating very small diametric mismatch between the two articulating surfaces, which help promote fluid entrainment. As I alluded to, modern ceramics, in particular the zirconia toughened alumina, are quite fracture resistant. Despite that being the case, there are rare instances where you do get a brittle fracture. And in those cases, small hard particulate are liberated in the joint space, and it makes for what can be a challenging revision procedure. Due to their surface characteristics, ceramic heads are still used in hip replacement. Nonetheless, over the years, a number of surface hardened materials have been developed to avoid the risk of fracture. This slide displays two of them. The first is LFIT, which is a hardened cobalt chrome material. It's created through a high energy process that's used to impregnate nitrogen into the surface. It's been marketed in part based on claims of reduced friction and improved wettability, which can be quantified by the measurements of contact angle. In fact, LFIT is an acronym for low friction ion treated. Another surface hardened material that was developed is called tinidium. Tinidium utilizes nitrogen as well. However, in this case, the substrate is titanium. While both of the processes differ, one of the limitations that they share is that the depth of hardening is relatively limited. For example, the depth of hardening of tinidium is estimated to be about 0.5 micron. So around the same time, Smith and Nephew was investigating the use of the metal alloy zirconium 2.5 niobium due to its suitability for surface hardening. Zirconium alloys were already used in the nuclear industry due to the fact that they would readily oxidize and are corrosion resistant. So both oxidized zirconium femoral heads and knee femoral components are fabricated from zirconium 2.5 niobium. After the implants are machined, they're heated in oxygen, in the presence of oxygen, so in the air. This causes oxygen to diffuse into the material, ultimately transforming the surface to zirconium ceramic oxide. At the end of the process, there's an approximately 5 micron thick oxide, below which you have about a 2 micron oxygen enriched zone or diffusion hardened zone. So the ultimate depth of hardening is about 7 microns. And the benefit of this type of material is you have all the positives of a ceramic surface while retaining the fracture toughness of a metal. So oxidized zirconium implants are sold and marketed under the trade name Oceania. The composition was patented in 1989 and first cleared by FDA in the mid-90s. As displayed on this slide, the introduction was phased in that they were first used in partial hip replacement, subsequently in total knee replacement, and then introduced in total hip replacement. They've now been on the market in total hip and knee replacement for about 25 and 20 years respectively. A notable improvement was made to polyethylene in the late 90s with the advent of highly cross-linked polyethylene. Highly cross-linked polyethylene refers to polyethylene that's been subjected to an irradiation dose above 5 megarad. Irradiation breaks bonds within the polyethylene, creating free radicals. And adjacent free radicals can then combine, creating chemical bonds between adjacent chains. Any remaining free radicals can then be quenched through annealing or remelting of the material. So it's well known that cross-linking results in improved wear resistance for polyethylene. This process can be tailored somewhat. So if you want greater wear resistance, you can increase the radiation dose. And that'll result in a greater level of cross-linking and greater wear resistance. This relationship's not linear though, so there is a point of diminishing returns, at which point you're getting very little additional wear resistance with increasing irradiation. Also, there's a trade-off with mechanical properties. So as you're getting improved wear resistance, you're sacrificing a bit on the mechanical properties. And so because of this trade-off, it's important to strike the proper balance for your application. So for that reason, different formulations may be appropriate in hips and knees. In the late 90s and early 2000s, several different formulations of cross-linked polyethylene were developed and commercialized. Each had their own recipe, so to speak, so they all utilized different irradiation doses, different thermal treatments, and sterilization techniques. Since then, it's been much of the same. While some of these cross-linked polyethylenes have evolved, each large implant manufacturer has their own formulation. In the mid to late 90s, there was a resurgence in metal-on-metal bearings, specifically for hip resurfacing applications, which is a more bone-conserving procedure than hip replacement. So the image in the middle of this slide contrasts the bone preparation for each procedure. Hip replacement consists of resectioning the femoral head and much of the native femoral neck, while hip resurfacing retains the femoral neck and much of the femoral head. Similar to ceramic on ceramic devices, the design philosophy here is to incorporate small diametric mismatch between both components to promote fluid entrainment. The sizes offered are large anatomic sizes. So this is beneficial from a stability standpoint, so it reduces dislocation risk. And it's also beneficial because you'll have greater surface velocity, which will also be beneficial from a lubrication standpoint. Unfortunately, some of these devices had relatively high rate of revision and relatively high wear. In some cases, this was attributed to edge loading and malpositioning. Whatever the case may be, adverse tissue reaction occurred in some cases, and that led to many of these devices being withdrawn from the market. The Birmingham hip replacement device, which originally led to this resurgence, still remains in use as the clinical data for that device is quite good. It's not a growing market segment, but it's primarily used by a subset of surgeons who've had excellent outcomes. So this brings us to where we are today. And this slide displays the bearing combinations most commonly used in modern hip arthroplasty. These devices consist of a highly cross-linked UHMWPE liner locked into a titanium alloy shell. That alloy is typically titanium 6 aluminum vanadium or Ti6-4. The liner is then paired with either a cobalt chrome ceramic or oxidized zirconium femoral head. These heads are in turn locked onto one of a number of different types of stems, which are most commonly fabricated from Ti6-4 as well. Less frequently, ceramic on ceramic devices are used, in which case you have a ceramic liner. The femoral heads, the femoral stems and acetabular shell offerings also include both cemented and non-cemented options. Another thing I should mention is that the choice of implant is largely a surgeon decision. It's guided by the surgeon's experience and knowledge, as well as patient factors. A young, more active patient is more likely to get a ceramic or an oxinium head, while an older, less active patient is more likely to get a cobalt chrome head. Depending on the healthcare environment, cost could also play a role. I should mention that some manufacturers also have developed highly cross-linked liners that incorporate antioxidants like vitamin E. This was prompted by reports of oxidation in some retrieved specimen. At this point, it's still unclear whether there's an actual clinical benefit in using antioxidants. So how do these modern devices perform? So some countries maintain very comprehensive joint registries, and that helps track device performance as well as healthcare trends. So this slide displays a figure from the Australian National Joint Registry. As we've already discussed, some large diameter metal-on-metal devices had high revision rates, so this impacts the data for the broader class on this slide. In order to look at individual designs, you'd have to dig a little bit deeper. One thing that is clearly apparent from this slide is that highly cross-linked UHMWPE outperforms non-cross-linked UHMWPE. Another point of note is that the ceramicized metal group paired with XLPE has the best survivorship of any bearing combination. And this ceramicized metal group consists wholly of oxinium heads paired with XLPE. And I should have mentioned, when I say XLPE, I'm referring to highly cross-linked polyethylene. So this slide displays causes for revision. On a positive note, you can see that the total hip replacement procedure is quite successful. I think that was probably apparent from the previous slide as well. Nonetheless, implant longevity remains a focal point, particularly as patients today are younger and more active. Longevity is also important because revision surgery can be quite complex, particularly when the cause for revision is loosening, which, as you can see on this slide, is one of the top reasons for revision. These cases can be quite challenging because they're typically associated with some level of bone erosion, subsidence, or resorption. So this slide displays the wide range of acetabular defects that can be observed at revision. In some cases, there's little deformity in an intact superior lip. In others, there's a lot more bone damage superiorly. And then there are cases where the medial wall is completely destroyed. And in the most severe cases, you have both medial wall damage and superior damage. So at one time, the surgeon would have had to perform an allograft or tissue transplant before implanting a revision device. Fortunately, today, there are implants that can better address even some of these more severe defects. One material that's been used in such cases is trabecular metal. This material is built by depositing elemental tantalum onto a carbon substrate using chemical vapor deposition. The resulting structure has interconnected porosity and is reported to have modulus similar to cancellous bone, which has benefits from a stress shielding perspective. It can be fabricated, it can be fabricated both in the form of a shell or an augment, which you can see in the images on the right. When this was launched, it was quite successful as porous structures were a bit limited. Today, that's changed quite a bit with the additive manufacturing process being introduced into orthopedics. So I imagine most of you are familiar with additive manufacturing to some extent. While there are multiple benefits of additive manufacturing, one is that it allows us to make structures that would be very difficult, if not impossible, to make through subtractive manufacturing methods. The additive manufacturing method that we use to make titanium shells and augments is called selective laser sintering. I have a short video I'd like to play. So in addition to making acetabular shells, which was the finished product you saw in the last video, additive manufacturing can be used to make a wide variety of augments, as I've also mentioned. So there are various kinds of acetabular defects that a surgeon can encounter on revision. So it's essential that we provide a wide range of options. The image at the bottom right corner displays multiple acetabular augments that we offer. And these augments can be attached in various configurations. Some of those are shown in this middle image. So there's some amount of freedom from a positioning perspective before the augments and shells are locked into place using screws. Once locked into place, bone cement is used to further fix the position of the augment relative to the shell. Due to the additively manufactured porous structure, bone can then grow into the surface to provide long-term stability of both the construct and defect. So there's a trend in orthopedics towards customization. The Hospital for Special Surgery in New York, which is one of the US's renowned hospitals for complex surgeries, has partnered with Lima Corporate to develop a 3D printing facility on site. So in the future, there may be some level of customization to implants, and that could be particularly useful in complex revision scenarios. So this trend towards customization is occurring in the primary joint replacement setting as well. One example is custom cutting guides, which are used to prepare the bone for the implant. If your implant isn't correctly aligned within your body, device performance and patient satisfaction will definitely be impacted. Using a preoperative MRI, a 3D model can be created of the patient's knee. Using that model, custom cutting blocks that fit the patient's unique anatomy can be designed and fabricated from nylon, and that's also an additive manufacturing process. This image on the right displays these guides on a skeletal model. Excuse me. The bone cuts are made through these slots. And so not only do these cutting guides allow for precise bone cuts for proper fit and alignment, there may also be a benefit from a health economics perspective, as there's been reports that these visionary cutting blocks reduce OR time and also the number of instruments that need to be available in the OR. As I highlighted in one of the earlier slides, dislocation is among the leading causes of revision. This has led to the development of dual mobility systems, which have improved stability. Dual mobility designs incorporate a cross-linked polyethylene insert that can articulate against both a femoral head and acetabular component. Both designs displayed here incorporate features that result in improved impingement-free range of motion and reduced dislocation risk. So I'm going to switch gears a little bit and talk about the future. And there's several different trends in orthopedics right now. One of which that is getting a lot of attention is focused on cost reduction. This is actually an area where there's global interest and pressure, not only in established markets, but also in markets where cost is a barrier to entry. So while it's certain that some of these efforts will play a part in shaping the future of joint replacement, in the interest of time today, I'm going to focus more on technologies that are being developed and could evolve and improve as we move into the future. Okay, so the first of these technologies is robotics. So this is a bit of a continuation of our earlier discussion about the importance of bone preparation and implant placement. So there's a variety of systems that have been developed to assist with joint replacement surgery. These can range from larger variety with surgical arms, as you can see here, to those with a much smaller footprint, which incorporate what can be called handheld robotic technology. I'm going to play a short video in a minute to demonstrate how the handheld robotic technology works, but I thought it'd be worthwhile to briefly describe at a high level, what the procedure entails. So during the procedure, the surfaces of the femur and tibia are mapped and other anatomic landmarks are registered. This allows you to plan and predict how a specific implant will be placed and has the potential to simplify soft tissue balancing, which is important for joint kinematics. Once you finalize your decision, the handheld cutting instrument will only operate in the desired locations. In other words, it'll keep you from removing too much bone or too little bone. So while this is more of a marketing video. It'll give you a good feel for how the system works. So at this point, I'm going to briefly divert to non-surgical interventions. There's data from focus groups that indicate patients would rather take a pill every day for the rest of their life than undergo a surgery such as joint replacement. There's no such pharmaceutical solution today. There are some patients that do take supplements such as glucosamine, chondroitin, or collagen peptides. The evidence on their efficacy is mixed, and I'm not aware of any pharmaceutical solution on the horizon, but one day there may be an improved one that could treat osteoarthritis. Another area where there's likely to be continued activity is joint injections. Currently, there are several treatments available that use hyaluronic acid injections. So hyaluronic acid is a constituent of your natural synovial fluid, which is your joint fluid. And some studies indicate that these products can delay the need for joint replacement by up to 2 years. So as we move forward, I expect there to be continued research in this area, and with any luck, further improvements. Like other industries, orthopedics is trying to determine how big data and machine learning can be leveraged. I don't have a specific example to speak about here, but just thought I'd walk through it conceptually. So a lot of data is collected during the course of care. As part of the hospital process, they're collecting general demographic data, so height, weight, age, sex, preconditions. There's also imaging data collected both pre and post-op. There's surgical details related to the surgery, for example, surgical approach, which I haven't talked about today, but there are different surgical approaches that can be used for hip replacement. There's also data related to the implant, including size, design, whether cement was used. And if that can be connected to outcomes, you may be able to gain some valuable insight. And by outcomes, I mean not only survivorship, but also functional scores, patient-reported outcome measures, or kinematic or joint mechanic data that can be collected in a gauge lab. So conceptually in the future, surgeons may be able to use a repository of information to guide their decision on the best treatment for an individual patient. Infection prevention is another area where there's a lot of activity and potential for improvement. There are several technologies being studied by different institutions and companies across a wide range, using a wide range of approaches. You see publications examining the use of antibiotic coatings. Also, you see publications looking at antimicrobial coatings like silver. There's also been research looking into the possibility of doping polyethylene with antibiotics, as well as studies looking at nanotextured metals, the idea being that the texture would disrupt biofilm formation and interfere with the attachment of bacteria and viruses. So there's certainly challenges in this space, but hopefully there'll be progress, because this isn't only an issue for joint replacement. It's an even larger issue in fracture fixation. where trauma products are generally used. And in those cases, you can have open fractures where reported infection rates are sometimes 10% or higher. While joint replacement is the most common procedure used to treat patients suffering from severe osteoarthritis, there's also cartilage procedures that are performed in less severe cases. In some cases, basic chondroplasty is beneficial. So this is a procedure that involves smoothing of degenerative cartilage and trimming of unstable cartilage flaps to stabilize and treat lesions, or chondral lesions specifically. Another treatment for localized cartilage defects is called Mosaioplasty. It's a surgical procedure during which multiple plugs of cartilage and bone are removed and transferred. The healthy tissues are taken from non-weight-bearing regions and then transferred to damaged weight-bearing regions. It's a minimally invasive procedure that's performed using an arthroscope, so the incision's about the size of a straw. Switch over to the browser now, just bear with me. Okay, so while their scope is limited, there are some synthetic cartilage technologies that have been developed. One is called Cartiva Sci. It's a osteochondral defect repair implant designed for treatment of the big toe. It's a synthetic hydrogel polymer composed of polyvinyl alcohol and saline. Another synthetic cartilage device is BioPoly. It's a combination of hyaluronic acid and UHMWPE that's targeted for small defects rather than severe osteoarthritis. Both of these technologies have limitations, and neither is currently amenable to large joints, but it's possible that there may be some developments that improve synthetic cartilage in the future. So there's also a few regenerative therapies that I wanted to highlight. Let me go back to the browser, sorry. The first is microfracture, which creates a new blood supply to stimulate growth of new cartilage. During this procedure, a sharp tool called an awl is used to make multiple holes in the joint surface, reaching the subchondral bone. This creates a healing response as new blood supply can reach the joint surface, bringing with it new cells that'll form new cartilage. So while this is a relatively straightforward procedure, there are some drawbacks. For example, the regrown cartilage is primarily fibrocartilage as opposed to true hyaline cartilage. So the regenerated cartilage does not have all the same characteristics of the native hyaline cartilage. New procedures are using this same sort of idea, but smaller holes are being used and different instruments are being tried. So the research continues in this area. Autologous chondrocyte implantation is another procedure that's being investigated. This procedure involves harvesting healthy knee cartilage from the patient. This tissue is then treated to facilitate expansion and cell multiplication. So there's some graphics here showing that. And then these expanded cells are placed onto, expanded tissues placed onto a collagen membrane that can then be sent back to the surgeon and shaped to match the defect and implanted. Lastly, within the past few weeks, a product developed by Cartiva received pre-market approval from the FDA. This device is a porous resorbable scaffold that can be used to treat local cartilage and osteochondral defects. So regenerative therapies continue to be an active area of research and development. So since I was a student 20 or so years ago, there's been a belief by many that regenerative or cartilage-based technology is on the horizon. However, the development of such a solution has proven to be very challenging, and overcoming it will be quite the accomplishment. I remain excited to see how these developing technologies improve the treatment of osteoarthritis hip replacement procedures as we know it today. And I thank you for your attention.
Okay, Amit, thank you for an excellent talk. Look forward, we've got some interesting questions and I'll come to them for you. One question is, how does the type of implant affect the recovery time?
So that is a good question. So in the primary setting, and actually I should back up a step. So I think for total hip replacement, what impacts the recovery time more than perhaps the device itself is the complexity of the surgery. So if you have a situation where you're going to have to use augments, or there's you're going to have longer OR time, the procedure is going to be more complex. I think most manufacturers make devices that have, at least their primary devices are similar in complexity and therefore have similar OR times.
Okay. In the presentation, you talked about anchoring on the hip side, either using cement or screws. Can you talk about the combinations used and why they're used?
Yeah. So historically, there was a time where our surfaces were not as well developed for bone ingrowth or ongrowth. So using cement was a common way to attach the implants to the bone. Currently, we have a lot of good porous surfaces that can be implanted with a press fit and that can accommodate bone ingrowth and ongrowth. And they perform quite well in the.
Okay.
So screws are, oh, sorry, go ahead.
No, go ahead. I'm sorry.
Okay. So screws are often used where they're to supplement that. Well, let me take a step back. So screws would be used for initial fixation. I think for the long-term fixation, you're still counting on the bone ingrowth. And so screws would be used at the surgeon's discretion based on what they're seeing in surgery with the condition of the bone.
Okay. I have a question about has there been any progress or what's the status of stem cell therapies to either avoid replacement or to delay the procedure?
So yeah, so there has been some research done using stem cells. I can't speak, so I can just speak to the outcomes very broadly. I don't have the details at my fingertips, but my recollection is that to date, they have not. There's not reason to believe. I think that they could help you avoid replacement completely. So I think it's still early days for a lot of stem cell research, and so that's not to say that something may not be developed in the future.
Okay. How long do the most modern implants last?
So that's a good question. So if you'll remember on the slide where I showed the registry data from the Australian Hip Registry, you can see that there's highly cross-linked polyethylene acetabular devices paired with a ceramic or ceramicized metal femoral head like Oceania. You'll see that, I think it was over maybe around 95% survivorship at about 20 years. I can pull that slide back up, but those are the numbers I'm remembering. So, the modern implants can last quite a long time. There is, of course, some variation based on patient activity, patient weight, a large number of factors. But generally speaking, modern hip replacement implants can last quite a while. But our patients are getting younger, and that's presenting challenges. And we do want to continue to improve implant longevity.
Okay. Do hip joints come in different sizes, or is it one size fit all?
Yeah, they do. They come in a wide range of sizes. So, so I think for cross-linked polyethylene liners, they typically range from a 22 millimeter inner diameter all the way up to a 44 millimeter inner diameter. And then the shells come in various sizes as well. So some of those polyethylene liners have various thicknesses. And there's a wide range of options that I didn't touch on. Even some of the liners have are what's called antiverted, and some have an overhang to promote stability. But it's not one size fits all. Certainly, there's in the existing offering from any company, there's a large variety of options.
Okay. How are these sterilized? Is ethylene oxide still used?
Yeah, so that's a good question. So the metals and ceramics are sterilized using gamma sterilization. The polyethylene is most commonly sterilized using ethylene oxide.
Okay. Early on, you mentioned that corrosion was an issue with some of the metals first used. Are there still corrosion issues occurring today?
Yeah, so that's a good question. So all the metals that are being used in orthopedics today are relatively corrosion resistant. However, some are more so than others. So there's been some reports in the past few years that at the modular junction on the femoral side where the stem and head connect, you can get what's called mechanically assisted crevice corrosion. So in those cases, micromotion disrupts the passivated layer on the surface, and that results in two things happening simultaneously. You get elution of metal ions and consumption of oxygen from the fluid. And so because this is somewhat of an isolated fluid environment, that you can get a cascade of reactions that lead to an acidic environment being created. And so cobalt chrome in particular is susceptible to corrosion when the pH drops below a certain threshold. And that's, and I think that's less of a concern, or much less of a concern for other femoral head materials like oxidized zirconium or oxidium.
Okay. Trying to see what it looks like we've exhausted the questions. So you've obviously done a great job explaining, because everybody understands what you said. And I don't know if they're looking forward to their next hip implant, regretting they didn't have oxidium for the previous one, or like me, tending for a family member with a recent joint replacement. So thank you very much. And I do want to congratulate you on a job well done.
Thank you, Bill. I appreciate the invitation.
All right. And I guess the last question is, do you have any final thoughts to share?
Yeah. So I think, what I'll end this with is just reiterating that, total hip replacement is the gold standard today for the treatment of hip osteoarthritis, because it's highly successful. However, as patients get younger and more active, and as expectations have increased of what they want to be able to do with their devices, new challenges have come to the forefront. And so that's leading to further research, because we want to be able to ensure that we can meet tomorrow's challenges. And I have no doubt that the patient experience of tomorrow's patient will be improved, whether through incremental advances to current procedures or a transformative biological solution.
Okay, well, thank you very much.
Thank you.
All right, and I guess we have a final slide here. And there we are. This is our last program of this series. So we'll be back in September. We'll be looking at things like water harvesting using metal organic frameworks. We'll be looking at some industrial chemical successes based on biotechnology, and also looking at alternatives to the internal combustion engine. And most excitedly, we are hopefully in September being back in person, and our intent is to continue with a hybrid format with both in-person and online attendees. So as that goes forward, and hopefully things get better in terms of the pandemic, we'll look forward to seeing some of you in person in September. So thank you very much, and look forward to the remainder of the programs from the Science History Institute. And later in the summer, you'll hear more about the details of our fall series. Thank you.